Hi, good evening or good morning, everyone. I am Tim Morgo. I'm faculty at the University of Chicago, and I will be the moderator for this webinar. Welcome to this CHEST webinar on robotic bronchoscopy. We will be talking diagnostics and potential therapeutic applications. It is my pleasure to introduce the panel today. Dr. Jessica Wong Memoli. She's Director of Interventional Pulmonology at MedStar Washington Hospital in Washington. And Jessica, welcome to the panel. I have to say, I know that your paper, the meta-analysis from almost 10 years ago now, right? It's probably one of the most cited papers in peripheral bronchoscopy. We were just talking about that a few minutes earlier. And I'm looking forward to hear more about your studies and your practice with a robotic bronchoscope. It's also a pleasure to introduce my friend and colleague from Cleveland Clinic, Dr. Joseph Cicenia, who's a pulmonary consultant at Cleveland Clinic, author of several clinical trials on peripheral bronchoscopy studies, including the landmark study published in CHEST just 2 years ago now, the BENEFIT trial, with the lead author, Dr. Silvestri from MUSC. And then from Hong Kong, from Chinese University of Hong Kong, Dr. Calvin Ng, Professor of Thoracic Surgery. It's a pleasure to have you here, Calvin, today. I know you'll be sharing with us your experience with the navigation bronchoscopy and bronchoscopic ablation for lung tumors, including now some experience with the robotic bronchoscopic ablation. So looking forward to your talk as well. So without further ado, I want to just briefly describe the flow of this webinar. Rather than just give a talk for 45 minutes and then take questions at the end, we thought it would be more engaging and more meaningful to address your questions on the go. Therefore, after each lecture, that will take about 10 minutes, we will take a break for about 5-7 minutes for interaction and Q&A. And then we'll move on to the next topic. I know several of you have already submitted questions during the registration process, and we will make sure that those will be addressed. So I will start and set the stage with just a couple of slides because I think it's relevant to clarify some of the concerns in regards to diagnostic yield prior to starting looking into the data in more detail. But first, I do want to say that this webinar is sponsored by CHEST, but with industry support from Johnson & Johnson, the manufacturer of the Monarch bronchoscope. For more information about the device, please check the IFU. And also, please note that the faculty today will be compensated by Auris Health for this talk. And also on this slide, as you can see, it's relevant to notice that the opinions shared today are the opinions of the panelists and not necessarily the opinions of the company. So I will start with this because as I review the literature on bronchoscopy studies, which will be addressed in more detail by Dr. Joseph Cicenia, we are puzzled to see how many diagnostic yields are reported out there in different papers. And some of them may be related to the technology, some may be related to the experience and expertise of the bronchoscopist or the instruments being used once a target is reached. But a lot of it has to do with the way we define diagnostic yield. So I wanted you to reflect on a case like this. You have a spiculated nodule in a patient with emphysema, and you do a bronchoscopy, and your biopsy may show organizing pneumonia with multinucleated giant cells or non-small cell favor adeno, or an acute and chronic inflammation with some hemorrhage. So which one is truly actually a diagnostic specimen? I think we will agree that B is diagnosis. However, some studies will include A and C as diagnostic materials as well. Similarly, for a non-diagnostic specimen, necrotizing granuloma, an abscess with a specific infectious etiology, like either clearly a fungal culture that turns out positive, lung parenchyma with anthracosis, or a hamartoma. A, B, and D are actually considered specific benign diagnoses, while C is really a non-diagnostic specimen. But these are not very, very clear in the literature. And I think what authors of peripheral bronchoscopy studies or bronchoscopy studies in general, what we agree on is that once we get cancer, we know that's a true positive, right? But what are the true negatives for malignancy? Okay, maybe we can agree on non-diagnostic material. You get lung tissue or hemorrhage or blood clots, bronchial cells. That's pretty clear. Those are not representative of site. But what about those benign diagnoses? And that's where a critical look at the methodology of different papers is in order, because a specific benign diagnosis, something that's actionable, yes, that's likely a true negative for malignancy, and you could consider that a diagnostic material. You get granulomas, necrotizing or non-necrotizing, a hamartoma, or a clear infectious, right, with a specific etiology. But what about these inflammations, acute and chronic inflammation, or lymphocytes, neutrophilic inflammation, organizing pneumonia, multinucleated giant cells, or scar tissue in different forms and shapes? Those are non-specific benign diagnoses, and they're not truly actionable because they're not firm pathologic diagnoses. So depending on how one defines the diagnostic yield, and especially the non-specific diagnosis, the yield will vary from paper to paper. And again, maybe this technology related, but very likely also the yield depends on the way we define it. We're familiar with the Acquire registry by Dr. David Ost, who probably used one of the most strict definitions in bronchoscopy studies, because that definition did not allow for follow-up. The specimens were considered diagnostic either as cancer or a specific benign diagnosis at the time of the procedure. But other definitions are more loose, like one used by Dr. David Fielding in one of the papers that used the Ion robot, the original paper actually, from a few years ago in 2019, where both specific and non-specific benign diagnoses were included at the numerator. So in addition, for those studies that actually allowed for follow-up and followed up patients with imaging or biopsies, if some patients were lost to follow-up, how was that data handled? Are they completely excluded from the analysis? Are they considered false negative, in which case you create a worst case scenario, or true negative, and you include them at the numerator, in which case you may overinflate the diagnostic yield? And this is not a trivial issue. To me, the best definition comes from the paper that Dr. Joe Cicenia was co-author, and again, the author led by Gerard Silvestri and Alex Chen. This is the benefit trial published in CHEST. And the same definition was used by a group from Memorial Sloan Kettering in a paper that used the ION system, was just published in CHEST as well. So one with ION, one with Monarch. These two papers use what I think is the healthiest definition of diagnostic yield. If you get cancer, then you have a true positive. If you get non-cancer, so non-malignant, if it's a specific benign diagnosis, yes, that is a true negative. But what about if it's inflammation? That's only considered diagnostic if you can prove in follow-up that either shrinks or disappears, or you confirm it's truly an inflammation with a surgical biopsy. And again, this is not just a trivial issue, because if you take a data set, let's hypothetically imagine 1,000 patients, and say 611 of them are malignant and 389 are not malignant. And then depending on how you handle the specific diagnosis, non-diagnostic, and specific benign diagnosis, and applying different definitions from the literature, we showed in a research letter that we just published in CHEST that you can show variability in yield of at least 20% for the same data set. just playing with different definitions, which is the reason why in the papers that are one of the reasons why in the papers published to date on diagnostic yield, which Dr. Josie Senia will elaborate more during this webinar, you'll see a bunch of yields reported in the literature. Again, of note, the papers that actually use a strict definition, like the Dackel paper in CHEST or Chan in CHEST, and our more recent one that we published in Annals of Thoracic Surgery, you'll see a yield in the high 70s, low 80s, versus yield in the mid 80s or even close to 90% in papers that have had a much looser diagnostic yield definition. So the truth is we need to look at the methodology rather than just believe a statement that one technology is better than another. And that should be my knee-jerk reaction when I look at the paper on diagnostic yield. And then again, maybe it's not just the diagnostic yield definition. Maybe there are other things that are impacting the yield, such as the tools used to the target or adjuvant technologies, which I know will be discussed in this webinar. So with that, my part is over, and I will pass the microphone to Dr. Jessica Wong-Memoli to talk to us about why robotics. Why do we even need this technology? Are they actually more beneficial than what we have so far available on the market? Jessica?
All right. So I really enjoyed Tim's discussion because he basically shot holes in my entire famous meta-analysis, right? But we're going to first talk about robotics, and then we'll talk a little bit about that study. And now looking back on it a decade later, why it's probably not, although everybody likes to quote it because it's probably, was sort of the first one to look at all of this, is not the greatest of studies. Oh my goodness, did I just say that? All right, let's see. Make sure I can move forward. Uh-oh. Okay, so I'm really going to go into why robotics and even really talk about what they are, because I think there was a question about really what's a bronchoscopy robot. So I'm just going to go through a little bit of what some of the previously reported diagnostic yields prior to robotic technology coming out. What are some of the advantages, and then touch briefly on some of the sort of the gold standard, and then just give a quick case presentation at the end. So ultimately, robotics falls within a realm of bronchoscopy called navigation bronchoscopy. Some people call it advanced diagnostic bronchoscopy. I think that's what the AABIP calls it. And essentially what we're talking about is not just regular conventional flexible bronchoscopy trying to get out to a peripheral lung nodule, but really a bronchoscope, whatever kind of bronchoscope, using extra technology to help you either visualize, reach further, maintain your position, or get you to the lesion a little bit more accurately. So there's a bunch of different technologies that people will use within this description of what navigation bronchoscopy is. Sort of from least expensive to most expensive, we'll talk about just regular flexible bronchoscopy with some added technology. So there's a radial ultrasound, which is the tiny ultrasound probe that goes through a working channel of a regular bronchoscope, and it'll give you a radial image. And this is sort of just an example of an image showing that your ultrasound is within the targeted nodule. Then there's ultra-thin bronchoscopy, which is essentially a smaller bronchoscope than a conventional bronchoscope. So a conventional bronchoscope is about 5.8 millimeters external diameter. With some of these ultra-thins, they go down to about 4 millimeters and some even smaller, while maintaining at least a 2 millimeter working channel, so you can get all of your biopsy instruments through it, as well as the radial ultrasound. So this was sort of the quote unquote cheapest method and sort of what was out there first. And I'm going to tell you, it's what I had until I got my robot about a year and a half, not quite a year, and 2 years ago. But it certainly allows you, if you know how to look at a CT scan and get out to a lesion, allows you to get out to things. Okay. And we'll talk a little bit about what the diagnostic yield is in some studies. Some people have the privilege of having a cone beam CT while they're doing bronchoscopy, which I think is amazing. So you are sitting there with your bronchoscope and you have your cone beam CT, and you can sort of give a scan of the lungs while your scope is in there, and it says, oh, you need to go more anterior, more lateral, wherever with your scope, and that can help direct you to your lesion and then sort of verify that you're within a lesion. Then we get to all the fancy electromagnetic navigation systems. So electromagnetic navigation came out probably about 2008, 2007, 2008, really started growing. And it was a big push. Oh, this is great. It's GPS for your lungs. It's fantastic. You have this guy standing there holding the scope, and then you have a virtual image of the lungs, and it's telling you, oh, you're going to take this airway versus that airway. But then at some point, you sort of don't really have a visual image of your airways anymore with your bronchoscope, and everything is based on this ball that tells you you need to go up or down or left or right. And you're just kind of moving in space, trusting that this technology works. But it was amazing because everybody's like, oh, it's going to be great. It's GPS, it's GPS. And then the other company that came out was Varian, who came out with their sort of electromagnetic navigation system called SpinDrive. With both of these systems, as well as with the bronchoscopic transparenchymal lung nodule access, which is Archimedes, there's still a person standing at the head of the bed holding a scope. And you know, some of these patients, they like to cough. So scopes get dislodged. If you have the privilege of having a fellows never stand still, like scopes end up where they're not supposed to be, and you got to get back to where you were, and things like that. So those are some of the other advanced technologies. And then there's lung vision, which is what's called augmented fluoroscopy. And so you're still doing a bronch like you normally do, but they take the CT and they fuse it with your C-arm fluoroscopy, and they give you a little bit more directional capability. And so in the same way sort of that you're still using your understanding of the CT sort of merged with the fluoroscopy can kind of tell you, oh, you need to be a little bit more anterior with your scope, or a little bit more lateral, or maybe more medial with where you are to try and get to a lung nodule. And then about 3 years ago or so was the robots. And, there's a lot of excitement in the world of peripheral lung nodule navigation when you talk about robots. So the two pictures that you see down there are actually the Monarch Oris robot. And essentially what a robot is you have your bronchoscope attached to two robotic arms, or one robotic arm if with the Ion Intuitive. And instead of being the bronchoscopist holding the scope at the head of the bed or wherever you hold your scope right there with the patient, those robotic arms, those control the robot, those control the bronchoscope, and you're sitting there either with a little handheld cursor, a little bit like an Xbox controller, or sort of a ball, other device that controls the motions of the robot. So there's some, perceived advantages of being able to have smaller movements with the movement of the bronchoscope. There's also the stability of it because it doesn't move. Your patient's sedated, intubated, and the arms are still. So you don't have like some, first year fellow holding a scope and things ending up somewhere else. So there's the stability of it. In addition to all the other technology. So all these robots kind of combine some of the electromagnetic navigation technology with the stable robotic technology, as well as some of these advanced CT guidance systems. And so that's really sort of what we're talking about today. Just to take a step back, looking at some of these other technologies about sort of how good they are, we'll take a step back to the radial ultrasound probe. So this is, again, the thin radial ultrasound probes coming through the working channel of a regular bronchoscope, an ultra thin bronchoscope. And there was a study by Nicole Tanner that was published in Chest in 2018. And we used a pretty rigorous definition of diagnostic yield, or diagnostic versus non-diagnostic. And as you can see, the yield's not so great, right? So sort of overall, everybody throws out these numbers. We try to get to a yield of about 70 because that's what, lo and behold, Dr. Wong's meta-analysis said. And we're looking here at a diagnostic yield of only about 49%. And that's pretty terrible considering the comparator is about 37%. So why are we using this, right? So it's not significantly different. So it's great that we have this technology, but maybe in and of itself, it's not enough. Some of the meta-analyses that have been put out there, and again, we always have to look at meta-analyses with a little grain of salt because you're taking a combination of a bunch of studies and you're trying to use everybody's definition and think that it's all the same result coming out. So in these, the sensitivity in the Steinfort article in ERJ was 49 to 88%. And then in the Ali study in respirology, they had a diagnostic yield of 70%. So in both of these, we're still sort of about 70%, but potentially even less. Okay, so, and then this is the NAVIGATE study, which is a prospective multi-center cohort study, which again, a bunch of people all together. And again, diagnostic yield about 70%, right? So, but here we are with the pneumothorax rate that's pretty low. So now we'll talk about my study, which was published in Chest almost basically a decade ago. And so essentially what I did was I took a whole bunch of studies that talked about the various guided technologies. And at this point, when this study was published, there weren't robots yet, but there was a few electromagnetic navigation studies, a few CT guided biopsy studies, CT guided bronchoscopy studies, some radial ultrasound studies, and some ultrathin and guide sheet studies. So basically lumped them all together and said, here's the weighted diagnostic yield of 70%. Well, there was a huge range, right? And Tim kind of showed you even within the robot studies, there's a huge range. And those range from sort of 60s to upper 80s. And there was, everybody's like, the gold standard is to get to about 90%. And ultimately what we found, at least in this meta-analysis, is that about 70% with the pneumothorax rate, about 2%. With a chest tube rate, less than 1%. So we're still stuck with this idea that our diagnostic yield is not wonderful. It's not terrible, not wonderful, not as good as a CT guided biopsy, but pneumothorax rates are much, much lower than CT guided biopsy, which is as high as about 25%. And so then the next sort of big study was the Choir study from OAST, which Tim mentioned, which was a multi-center registry database with the endpoint of a diagnostic yield. And then secondary was sort of each technology. And in this one, the results were even worse, which is not unexpected because in this study, they were a little bit more they paid attention a little bit more to how the definitions were, which is exactly what Tim was talking about, right? The definitions of what is diagnostic and what is not diagnostic. The interesting part down here is all this fancy electromagnetic navigation. We're like, woohoo, yeah, it's going to be really great. It's really going to be great. Only had a 40 to 50% diagnostic yield, which doesn't make that technology look so great. But nevertheless, it's what was there. Complication rate of 2.2%. So sort of in line with everything else with a pretty low pneumothorax rate, right? So here we are today, it's 2022, and we have robots, which is what we're talking about. So the two robot technologies are Monarch, which is Auris, owned by Johnson & Johnson, and then Ion, which is Intuitive, which is the company that makes all this surgical Da Vinci robots. While the way that they work, and not being an engineer, the way that they work is just a little bit different. So Monarch, the way they work is they have this navigation algorithm and computer vision. So they take the virtual image, mirror it to the bronchoscopic image, and sort of then use that together with some AI to guide you to the nodule. And then it uses an electromagnetic platform, sort of like the Super D and Spin, to kind of tell you, yes, you are where you think you are, this is where you are, but it's got a little bit of extra tools. The the big thing with Monarch is that the bronchoscopy scope allows you, it's ultra thin, so you kind of get out more peripherally and you can still see what you're looking at in a lot of cases. In Ion, their catheter camera is shape sensing. So their system knows exactly where that camera is at each turn and point. And again, you have a camera that goes out. It's actually a little bit smaller than the Monarch camera. However, it doesn't have a working channel. So once you get to the lesion that you believe that you're out, your scope comes out. So you sort of lose visualization there. So while they're both robotic, so they both have arms and you control it remote, sort of not right at the patient, and they have all this different neat technology. They have their pluses and minuses. So both companies sort of say the same thing about what the benefits are. So number one, extended reach, right? So Monarch says, we got reach. You can get out to peripheral nodules. Ion says the same thing. They say there's more stability. So you can, because the robotic arms are stable, they don't move, things aren't moving around, you are where you think you are, and then you have more control and more precision. And so that's sort of the selling point for both systems. And why do we care? Why do we need to be able to get out to these itty bitty little things out there? And I think Dr. Ng is going to go into this a little bit more, but ultimately the reason why we want to do it is because we want to be able to reliably get out to a peripheral lung nodule for those patients who are not automatically going to go to surgery and get it cut out, right? We want to potentially do therapeutics. So your patient comes in, they get their robotic procedure, they get staged, they get treated, and they're done, hopefully, right? So that's sort of the holy grail of all this peripheral lung nodule stuff. And I didn't keep track of how long I'm going. And I just wanted to show some pictures real quick at the end of what the Monarch robot imaging looks like. So this is a patient, she's 83, and she had this left upper lobe sort of lobulated nodule that had been getting bigger. So this is what the bronchoscopic image looks like. So this is the actual bronchoscopic picture. And as you're going in, the robot gives you sort of where you are along the path to your target. It also gives you the pathway. So it's taking your bronchoscopic picture and matched it up to a virtual picture. And you have this path that you go to. And then it gives you this other image, which kind of melds the CT image with the virtual image so that you know you've got to go up or down to get to this nodule. And then they call this the Call of Duty sign, where you're facing right toward it. And hopefully you're a little bit closer than 5 centimeters. And this is my radial ultrasound picture. And this is sort of shows you how far up my scope went, and then how far my radial ultrasound went. And ultimately we were able to make a diagnosis on this patient. So it worked in this one, but it sort of just gives you an example. So that's the end of mine.
All right, Dr. Wang Memoli, thank you for a concise review of the literature. So as for participants, please use the chat room or the Q&A to ask questions. And I know there are several questions submitted, again, during the registration process. And I think we should start answering some in a couple of minutes so we can move on. But Jessica, there is one question in regards to training requirements for nurses and technicians. Can you briefly tell us how you implemented this and what kind of training your staff went through to start your robotic bronchoscopy program?
Yeah, so we got our robot in September of 2019. And what Monarch did was they actually took it was my thoracic surgeon who actually pushed to get it into the hospital first. So he got trained. They took both my thoracic surgeon and my tech out to California, which I don't think now, because it's Johnson & Johnson, they need to go out to California anymore, but it was like a quick out to California. They spent a day sort of understanding the technology, how to set it up, how to break it down, how to troubleshoot, and where all the pieces went, how to put the patient, where to put all the probes, from everything to how to clean the robot, where your scopes go, and all of that fun stuff. And then we started doing it, and with every, our initial cases, there was a rep at every case, and sometimes more than one. And and then they were there and they could help troubleshoot. And actually their customer service is actually really good. In the beginning, we had a few issues, and if a rep wasn't there and I called, they were always like, "Oh, Dr. Wong, it's great to hear from you." And they could fix things fairly quickly. So.
All right. And I see there are several questions in regards to training and competency. Competency is a strong word and involves a lot of judgment, but the training it is offered by the company. So for those of you interested, please contact your company representative, because there are training opportunities at their corporate office or in local regional centers. And I also have to say, as CHEST faculty, there will be training programs at the CHEST headquarters. In fact, there is a program on peripheral bronchoscopy that will also teach robotic bronchoscopy with different platforms, including Monarch, and navigation technologies. That course is scheduled for August of 2022 at the headquarters in Chicago. And just to be cognizant of some of the questions raised here, I see at least 3 or 4 questions in regards to cost, because that depends a lot on the healthcare system and the setup. Is this done in the bronchoscopy suite or in the operating room, etc.? We're not in a situation to answer those questions. Please, again, contact your company representative, and they can get back to you on addressing the cost issues pertinent to your institution. So now it's time to move on, because it's 5:33, and the next speaker, Dr. Joe Cicenia, will give us a critical review of the literature regarding the 2 technologies. Joe?
So thanks, Tim. My job really today is to review the literature. So just the facts, Jack. No opinions, just literature. And I'm going to try to format each of the studies that have been published on robotic bronchoscopy in a way that we try to compare them, the studies, best we can. We'll talk a little bit about how they define their yield. We'll talk a little bit about their patient population, and I'll kind of pick out subtle points from each study. And hopefully we'll kind of crescendo to a conclusion when we're done. So let me see, I can't. There we go. So just some disclosures, real quick disclosures, which everybody generally has. And the first study that I want to talk about which is really the first study and really clinical study on patients, on live patients in the literature, is by the original group. Really, it's probably it's probably the people who had and bought these systems commercially early on. So Erie, Chicago, several other places, and I think they did a really great job. They took this technology. They were the first adopters to use this technology, and they published their initial data, which I think is kind of courageous, because as you all know, when you're starting things out, there's a lot of bugs to go through and there's some growing pains. So this was 165 procedures, 167 nodules, and includes really the first Monarch procedures at all these clinical sites. This was done with first generation software. Again, this is not current software, so these are the first users right out of the box. Their diagnostic yield was defined as the percentage of procedures yielding a diagnosis based on final pathology. The follow-up test demonstrated alternative diagnoses, lesion growth, new lymphadenopathy mets, and the procedure is considered non-diagnostic. And they did have a follow-up of roughly 185 days. In terms of their patient population, you could see that here's their average lesion size. Most of their nodules were in the upper lobes. About a third were in the lower lobes, and I'm presenting this for reasons we'll talk a little bit about later. 70% of them were peripheral lesions, defined as the outer 2/3 of the lung, and 3/4 of them were solid. And I bring that up because 10% of them were ground glass, which may have an impact in how localization of the nodules was determined, because if you're using radial EBUS, you may have a hard time seeing ground glass nodules. And about 63% had a bronchosign, which I think is about average for most of the trials. And here's their data. Their overall yield was defined somewhere between 69 and 77%, depending on how the inflammation, we heard Tim talk a little bit about this before, and how you define inflammation in terms of your yield. So depending on how that was managed, if they actually had a follow-up or if they just considered inflammation as a diagnosis. So somewhere between 69 and 77%. And if you look at the breakdown of yield, you could see that it didn't really matter depending on where the nodule was located. Depending on the bronchosine, they had a 78% yield with the bronchosine, which, I think brings up questions of, did you have a direct view or not? Their localization success, they only had about 70% localization using radial EBUS, but maybe that's explained a little bit by their 10% ground glass nodules. Overall, they had an 89% navigation success, which is a combination of radial EBUS and whether or not they got diagnostic tissue. And you could see that in the rebus view, whether they had an eccentric or concentric view, it really didn't matter. Their yield was roughly the same. So maybe they perhaps overcame some of the more some of the challenges that we see with plastic catheter-based technologies, like some of the other navigational technologies. And look, even with no radial EBUS image, they still had a diagnosis in 1 of 4. So, I think that this was a pretty nice paper that they put out. Interestingly, they were able to see they had visibility in the patients that had visibility. 80% was their yield. So not every visible lesion did they see. Did they get a diagnosis? And you wonder if this is due to tool failure. And you could see that as the nodules decreased, the yield, the nodule size decreased, the yield also decreased. So this leads into the benefit trial, and this was going on sort of concurrently to that registry trial. And these weren't commercial use patients. This study was done for the specific purpose of getting some data. And this was several sites. It was us at the Cleveland Clinic. It was MUSC. It was Alex in St. Louis. And 54 procedures, 54 nodules, 5 different sites like I talked about. And the primary outcome was lesion localization with radial EBUS. Our diagnostic yield, I think, was a little bit more strict. It was a biopsy that resulted in a specific malignant process or a specific diagnosis of a non-malignant process that explained the presence of the lesion, such as granuloma or you saw fungal elements. Inflammation was you could see was considered diagnostic only if there was improvement or resolution or follow-up if confirmed by surgical biopsy, as Tim spoke about before. Atypical cells notably were considered as non-diagnostic in this study, and all follow-up was for at least 1 year. And you can see the nodule properties on the right side of this slide. You can see the average nodule size was 23 millimeters, which I think is a standard size here. 60% had a bronchosine, and about 30% were in the lower lobes. The majority were in the upper lobes. And here's our data. Overall lesion localization as defined by radial EBUS was 96%, but the overall yield was 74% when you had a radial EBUS view. So there's a drop. So you could localize, but not in all cases did you get a yield. Our categorization was defined as by 30 millimeters. We didn't subgroup beyond that, and there was really no difference whether it was a large lesion or a mass or nodule. Tim's group, specifically at Chicago, looked at factors associated with the diagnostic accuracy of robotic bronchoscopy with a 12-month follow-up, right? So they looked at 124 consecutive patients, and they specifically looked to see what fed into yield and what fed into maybe not getting a yield. They had a 12-month follow-up, at least a 12-month follow-up on all of their patients. And again, similarly, they had a localization of 94% based on system imaging, but if you looked at it just by radial EBUS, they had a localization of about 82%, an overall accuracy of 77%. And their accuracy and their yield was contingent mainly on a radial EBUS view, whether it was concentric or eccentric, it didn't matter. But if you had a radial EBUS view, you had a high outcome of getting a yield. If you didn't have a radial EBUS view, your yield dropped to 38%. And their bronchosine notably was non-significant. Again, kind of feeding into this concept that as long as you could get there, there's a pretty good chance that you're going to get a diagnosis. And when they did a multivariate analysis, again, the only thing that popped out was whether or not you had a radial EBUS view or the nodule was big. So let's move into the ION data. This is one of the first trials looking at ion data. This is Ganesh Krishna's study. 52 procedures, 59 patients. And this includes, sorry, this is not Monarch. This is a typo. This is ion procedures at one site. All cases were completed with ion, and they were confirmed using cone beam CT, or localization was confirmed with CBCT. Their diagnostic yield, however, wasn't clearly defined in the trial. Any inflammation was considered diagnostic. Atypical cells were also considered diagnostic if the report said atypical cells favor malignancy. So this is a pretty generous diagnostic yield definition. Follow-up time wasn't really defined, and there was some radiograph follow-up for less than a year. So looking at yield here, you kind of have to take it with a grain of salt. Here's their nodule property table. Their largest diameter nodule was 22 millimeters. Most of their nodes were in upper lobes, very few were in the lower lobes, and they had a little bit less of a number of bronchosine nodules, less than what we usually see in these trials. So whether or not that impacted things, not particularly sure. 85% of their nodules after their initial navigation was localized using cone beam CT. So they had a localization rate, I think, that we could say around 85%. And if you look at their data, they had an overall, again, using their definition of yield, an overall yield of 83%. Depending, again, how you look at it, you have to sometimes take this with a little bit of a grain of salt. This is Arthur Sung's trial out of Stanford, and this was the first publication with ion in the literature. 30 procedures, 29 nodules. Again, this is just purely a registry trial, an observation of this is what we did at our site. Radial EBUS was used as confirmation, and their diagnostic yield, again, because it was sort of an observation trial, wasn't specifically defined. Follow-up was for at least 6 months. So a very kind of generous and liberal definition of yield. And here's their nodule properties. Their nodules were largest diameter in any dimension was 15 millimeters. So they kind of attack smaller nodules. A bronchosine present about 60%. And here's their 93% localization rate. There's their localization data. And kind of, again, using their somewhat liberal diagnostic criteria, their diagnostic yield was at most around 80%, which is not dissimilar to what we saw in real world clinical studies that were done with Monarch. And then here's, I said up until now, probably the definitive clinical trial or clinical observational trial with the ion robot. This was out of, this is the Memorial Sloan Kettering Group, Mo Chawla and his partners. And 131 procedures with 159 nodules, all ion, all done at one site. And their primary outcome was diagnostic yield per lesion. Their diagnostic yield was very, I think, really hit the mark. It was very similar to the kind of stringent guidelines we used in benefit. Malignant was considered diagnostic, and non-malignant, had very strict yield definitions. All follow-up, again, was for a year. So I think their data here is something to look at and apply to your data in the real world. Their average lesion size was 18 millimeters. Nice spread of lower lobes, 34% of nodules in the lower lobe, and a bronchosine in 62%, consistent with other trials. In terms of targeting, it's a little hard to look at it in this trial. Again, it was probably hard for them to report out because it's a sort of an observational registry trial. They only used radial probe to look at their targeting numbers in 85% of cases. In the other cases, they used 2D and 3D fluoro. So we kind of have to keep that in mind as we're looking at their targeting. They stated their overall localization was 98%, but it's unclear if there are any image guide adjustments that were made at the time. I don't think there were. And again, some of their targeting was based on both radial probe and 2D, 3D fluoro. So I think that their targeting and their localization was pretty high, although putting an exact number on it, I think, is difficult. And if you look at their yield, their overall diagnostic yield was 81%, consistent with what we've seen before. However, if you kind of divide this up between nodules bigger and smaller than 20 millimeters, you're going to see a kind of a big drop off once you get under 20 millimeters. But I think this is consistent with what we've seen before. Again, it's real world patients, real world situations. First 130 or so nodules. Again, courageous kind of trial to kind of put out there when you don't know what the results are going to be. And I think they had a pretty good yield. This is sort of a summary of the studies that I showed earlier, and Tim showed I've adapted this from Tim's, so I have to give Tim some credit for this trial, for this slide. And you can see here when you look at all the studies, for the most part, other than Krishna's or Ben's study in 2021, BronchoSign about the same. Their navigational success or confirmation all very high, 85 to 95%, depending on how you look at it. And if you look at their yield, it's all kind of floating around the same number. Now, what's our basis of comparison? I guess you could look at Navigate and say 73% for first gen EMN. So did we get a little bit better with this? I think we probably did, and I think there's probably reasons for that, like we talked about earlier. So what have we learned from this? I think the proposed advantages of robots are on the left side of this slide. Certainly a better tip integrity, right? We're not dealing with plastic catheters that go wherever the airway or the tool wants you to go. We have much better tip integrity with the robotic scope. There's greater reach to the periphery. There's perhaps direct visualization of the lesion, and there's certainly a proposed advantage of better overall yield. However, what does the literature showed us up until this point? The yield is increased only modestly. Localization seems improved, but we're not 100% sure based on some of the definitions that we've used. There's some mention of direct visualization, but really only in one trial. And still, even when direct visualization occurred, the yield wasn't 100%. And the other interesting thing is yield seems not connected to radial EBUS confirmation, or at the very least, it seems not connected to whether you have an eccentric or concentric lesion. And you wonder if it's tied to the image guidance as much as it is the tip integrity. And it's really hard to kind of tease that out because these studies weren't really designed to show that. But I think as we move forward and design better studies, these are the things we need to kind of think about. So, my last slide, where do we sort of go from here? I think will AI improve, the algorithms, the ENB algorithms, the airway recognition, shape sensing to improve navigational success as we go along? I think there's promise here because, what AI does, it takes everybody's data, kind of incorporates it and makes the algorithm better. So I hope it will, but we don't know for sure. Can the addition of real-time imaging enhance targeting and yield? I think these are things that we need to think about as we move forward. And and as we think about that, is there a role for combining the tech? So do we take robotic bronchoscopy and add image guidance to that, whether it be SIOS, cone beam, lung vision, tomosynthesis, or do we integrate it within one platform, which NOAA Robotics is working on now? So in conclusion, I think interpretation of the current data, I think, is difficult due to differences in study design and intended outcomes. However, I think we could kind of say that localization seems similar across both robotic platforms, although, again, the definition sometimes is a little fuzzy. Yield lags behind localization for undetermined reasons. It's unclear at this time how much image guidance has impacted yield. Like I said, a lot of these trials were done with cone beam, and if it has impacted yield, to what degree. It remains to be seen if AI-driven advanced targeting algorithms can improve yield over time. I think it's something we should definitely kind of follow as we go along. And it really remains unclear if either platform can outperform each other, either in controlled published studies or real-world settings. So, look, I really have to say that for the people who went out and did these trials, and went out on a limb and kind of bared their dirty laundry or their good laundry, I have to give them a lot of credit. And I think as we move forward, we'll develop better trials and come to better conclusions. So I'll stop there. Thank you very much.
Appreciated, Joe. Thank you for a great review of the literature. There are a bunch of questions which I do want to address before we move on to the ablation part of the webinar, and with the risk of going over the time here. But there are several questions here that I'd like to discuss, and some of them I will answer, and some of them I will ask the panelists. So one of them that came a little earlier was in regards to, how far the bronchoscope can go, and that we can get in the same location with the diagnostic scope. That may be our clinical intuition at times, but then data is what data is. If you look at the literature, the REACH study by Alex Chen showed that when you compare the Monarch system with the P190 bronchoscope, which has a similar outer diameter, you can go farther into the lung with the robot. And the reason for that is the rigidity, the fact that there is a sheath and the bronchoscope that offers that stability, usually in the central airway, so you can actually use that muscle, that push of the bronchoscope. There was a theoretical concern that may result in trauma, and that's not been shown in the original cadaveric study or in the human trials. So yes, for the same size bronchoscope, the robot does go further, despite of what we may think at times. The other question was which adjuvant imaging modality is better. In the studies that were published to date, including ours, most people just used radial EBUS and fluoroscopy. Couple of papers used cone beam CT, and the paper by Ben that Joe Cicenia nicely reviewed for us. In about 15% of patients, the lesion was confirmed with the cone beam, and that requires some adjustment of the robotic arm. That was with the Ion system. I don't think we're at the point where we can say that one adjuvant modality is better than another. Personal experience is with radial EBUS and fluoroscopy, and the yield is what you just saw on the slides. Another question is, if the data in the diagnostic yield included EBUS, I suspect you're asking EBUS TBNA from the lymph nodes. No, those patients are excluded from the study. If a diagnosis is made on the radial EBUS, on the EBUS TBNA from the lymph nodes, then really there's a little role for doing a peripheral bronchoscopy. So when we talk about diagnostic yield here is from the peripheral lesion itself. And in regards to radial EBUS imaging, in our papers at least, if there was no radial EBUS image, the yield was much lower than if we got a radial EBUS image. And just to clarify what Dr. Cicenia mentioned, there was no difference if it was eccentric or concentric pattern, and that's actually reproducible now. I think a paper looking at the Ion system showed similar findings, and that's probably because once you're a target, if you actually work a target, if you insist, if you use needles, eventually the diagnosis will be made. And then one question, actually, I want the panelists to answer this, and Jessica and Joe, maybe you can chime in. This comes from a clinician asking about the fact that some insurance companies consider navigational bronchoscopy as experimental, and that may deny the procedure based on their quote unquote expert reviews. So how do you combat that?
Interestingly, I'm in DC, and I'm in the center of urban DC. So we have a lot of Medicare, Medicaid, and they don't actually give me a push. It's usually private insurance that gives a little bit of problem. But I'm not sure I've had any insurance companies deny the procedure. Usually what you can just tell them is that the ACCP recommendation as way back as 2013 is that a guided bronchoscopic technique should be considered if it's available. So if you have the technology and you can offer it to the patient, it's what's in the guidelines and the recommendation. So I don't think I've had anybody deny me doing a robot.
Yeah, it's a CPT code that is a new CPT code. There's no specific CPT code for robotic bronchoscopy. So it's the same CPT code that you would use for any kind of guided bronchoscopic technique, whether you're doing a Super D, a Lumicite, lung vision, whatever, radial probe EWC. It's the same code. It shouldn't be an issue.
I think there's a 31626. I'll double check.
All right. I'm going to address one more question here, and then we'll move on. in regards to the learning curve, I do not have an answer. Joe, actually, you looked at this in the past for navigation technologies. I think was like a number of 15, and then the yield started to plateau. That comes from super D times. I don't think we know that for robotic bronch. I would like to say that it's in the range of 25, but it really depends on lots of factors. A lot of it has to do with our hand-eye coordination and depth perception, etc. So we do not have an answer for that at this time, but that's something we're actually looking at.
Can I comment real quick on that, Tim?
Yeah, please.
Real quick. We have a lot of users at Cleveland Clinic, and we have a lot of so there's been a lot of learning curve observations that we've made, and I will say that there's a learning curve both for your staff, your nursing staff that are helping you with this, and you yourself as the operator, and that learning curve also is impacted by the size of the nodules or masses that you start off with. So if you're going to start off with a bunch of 8mm nodules, I think your learning curve is going to be a lot longer than if you started off with a 30mm nodule. So I think if you're starting off, my recommendation is to avoid the small ones, go with the big ones. Your learning curve will be much steeper.
All right. As we move on, I will answer some of these questions in the chat room, but I will pass the microphone to our thoracic surgeon in the room here, talking about ablation. Calvin, you're on, and please take your time. It's clear that we're going to go over time, so not to worry.
Thank you, Tim. Okay, so it's a real pleasure to be invited to talk about our small experience of bronchoscopic ablation for a navigational system. We haven't actually really done a clinical case in a robot to do ablation yet. It's sort of on a workflow. We're trying to work through some of that right now, but this is basically based on navigational bronchoscopy. These are my disclosures. So ablation, basically, as you well know, is a kind of local therapy, essentially, and it's often pitched against, SBRT or even surgical wedge resection. And conventionally, ablation, as you know, is most of the data is from percutaneous approach using radiofrequency energy. And in general, there's much less data than SBRT. So, often in MDTs, we'll be discussing, patients not suitable for surgery and sending them for radiotherapy. But you have to remember the conventional way of doing it is associated with a high risk of pneumothorax or even hemothorax, bronchopleural fistula, and has limited access from percutaneous route, depending on where the lesion is. And these reported complications can be as high as between 11 and 52% in some of the meta-analysis reported. Also, radiofrequency tend to have a smaller ablation zone because it's dependent on resistance and the conduction of the current. And once that's basically the area around the probe becomes charred, then that doesn't conduct electricity anymore. So it hasn't been very popular. And you also have to remember, behind all this, in terms of SBRT, although it's very safe, a significant proportion of patients do get radiation pneumonitis and potentially pneumonia in some reported analysis as well, up to 22%. One of the potential game changers for all of us is doing this through the endobronchial route, which is maybe associated with decreased risks of all of these complications, pleural-based complications essentially, and changing the energy that we're going to be using with regards to a microwave rather than radio frequency that produces a more predictable and a larger ablation zone. There are whole host of meta-analysis reviews out there essentially that compare the different local treatment modalities and the survivals and the recurrence rates, and it kind of depends on which papers you pull out and how you analyze which group of patients. This meta-analysis and review is from Yale, at Yale's group, and really looks at pulling out all the data from patients who have a definitive diagnosis, biopsy-proven diagnosis of non-small cell lung cancer, which is one of the strengths of this study. And they managed to find like 1,000 patients with who's had thermal ablation, mostly through percutaneous and mostly through radiofrequency, and versus, look at this number, is hugely more in terms of comparison, which is through having had radiotherapy. Hence, as I was saying, that a lot of the time patients are sent for radiotherapy and ablation is not even considered. And in this paper, basically, they found regarding overall survival, there was no inferior data that can be found when compared with SBRT. So this is kind of encouraging, at least on the superficial analysis. We started doing our first cone beam CT hybrid operating room bronchoscopic guided microwave ablation almost 3 years ago now. And this was the first case where there's a left upper lobe tumor. Patients already had lung surgery on the other side, doesn't have enough lung function. And with proper consent, we ablated that lesion. And this was the post-ablation 10-minute imaging. The first sort of collaborative international study was an ABLATE study of 30 patients that was discussed in abstract format recently in the European meeting. And essentially, the inclusion criteria are those patients who had biopsy-proven lung cancer and malignancy, and it cannot be too close to the pleura. It has to be more than 5 millimeters. And those patients who've gone through MDT who decline or cannot have surgery or SBRT. And of course, you need cone beam CT to essentially, confirm that you have successful navigation and ablation. And this is a prospective, of course, non-randomized or anything study. It's just to look at safety. And within the 30 nodules, 2/3 were for primary lung, whereas 1/3 were for metastasis, and 2/3 were on the outermost third of the lung, whereas 1/3 of the patients roughly were in the middle third of the lung. Nodule size is between 5 millimeter to 27 millimeter with a median of 12 millimeter. The technical success rate of reaching a lesion and ablating it and covering the whole nodule was 100%. And the mean ablative margin was about 9 millimeters. And we were just looking at safety. So the 1 month efficacy rate based on the follow-up CT scan was good, 100% that the ablated zone covered the lesion with no observed progression. In terms of adverse events, many people would be interested in these. One possible ablation device-related event was a mild hemoptysis that was just self-limiting. We didn't need to give any kind of transamine or anything like that to stop it. And there were 4 subjects who had 9 events that were, I would consider as relatively mild, that may be related to the study procedure itself. There were 2 cases of pleural effusion. One required pigtail drainage and some 2 post-procedural pain, 1 sort of inflammatory response with a low-grade temperature, and 1 case with post-ablation syndrome with regards to a low-grade temperature and elevated white cell count and a slightly sort of whitish out of the radiology and X-ray. There were no deaths or pneumothoraces in the 30 cases, and essentially we've shown that this kind of approach is a potential option for malignant lung nodules up to 30 millimeters in select patients who are not suitable for other types of treatment or decline other types of treatment with low complications and high technical efficacy. Outside of the ABLATE study, our own experience of those who did not meet those criteria, we also looked at, and it just so happened to be also 30 cases when we published this early last year. And in these 30 lesions, they had relatively moderate comorbidity index as expected because they were not really for surgical candidates per se. Mean age was between range of 54 to 87 years old, and the lesions were around 2 centimeters in size. Range from 8 millimeters to 3 centimeters. There's no blood loss really associated with this procedure, and they stayed for 1 day on average. There were a couple of cases that actually needed double ablation in the same session because the lesions were quite big, and we needed to make sure that the ablation zone covered the lesion. Couple of cases that we did within the 30 cases that we did a concomitant biopsy and showed with real-time, frozen section, for example, that it was a tumor, and then we proceeded with ablation in the same session. The whole procedure takes about 2 hours on average for these cases and involve a number of cone beam CTs, and the margins we got were about a minimum of 6 millimeters for these 30 cases. In terms of a double ablation, what we mean sometimes is this: when you have a big lesion, you would navigate and place the catheter, the antennae, microwave antennae in one side of the lesion, because you know you're not going to capture the whole lesion. And then after the burn, you'll re-navigate and place the catheter on the other side of the lesion in order to capture the whole lesion with a relatively good margin, as you can see here, after double burn. In terms of complications for these 30 additional cases that we reported, there were 2 pneumothorax that required a drainage, and just 2, what we call low grade temperature ablation reaction, 1 hemoptysis, again, that was self-limiting, and 1 infected effusion that required drainage and a more prolonged hospital stay for antibiotics. In terms of pain, it's interesting to see that over 80% don't have any pain at all after the procedure. This is our 30 cases. As we got better at it, I guess you can see a trend towards quicker procedural times, but there were some blips. I think we were being less selective in the cases that we're doing in terms of being able to navigate there or placing the catheter in the right place. So there were some challenging cases where we took longer to do to reach the lesion. Subsequent to those sort of 60 cases or so, we did have a case that had a delayed presentation of bronchopleural fistula after a bronchoscopic microwave ablation. And essentially the story was this: it was a right middle lobe lesion here that underwent ablation. And the catheter during the procedure, you can see we did not create a pneumothorax. We placed the Emprint catheter within, quite close to the pleura. We burned the lesion, which was satisfactory. And we actually sent the patient home the next day because there was no pneumothorax on the cone beam CT post-procedure. He actually presented 2 or 3 weeks later with some shortness of breath. An X-ray and CT scan showed there was a hydropneumothorax. We put in a drain and there was a persistent air leak, and you can see the track there into the middle lobe, and this is the burnt area that we corresponding to the procedure day. We placed an endobronchial valve immediately, and that stopped the air leak. And the next day, we're able to remove the drain, send the patient home, and 6 weeks later, we removed the EBV, and you can see the track has actually healed on the CT at that point. So, sorry. Skip that one. So you can also see that apart from ablating single lesions, you can also ablate more than 1 lesions in one go. You can see this is a very unfortunate lady who's already had a lobectomy and a segmentectomy on the right side, and then has multifocal adenocarcinoma, and now has a ground glass new change in the left lower lobe and left upper lobe. And we ablated both of these lesions. And these are kind of ideal candidates in some ways that you want to preserve lung function to ablate. And these are the 2 post-ablation areas on the cone beam CT immediately after the procedure on that day. A lot of people, of course, don't have cone beam CT, and I truly understand that. And we're kind of working towards introducing a potential mobile C-arm with a 3D CT reconstruction to replace cone beam CT in order to able this technology to be used in more centers. And we kind of looked at our first 10 cases of experience, and there were some limitations in seeing some of the pure ground glass opacities. But essentially, it can be done for biopsies, dye marking and ablation as well. This is the comparison of the image quality. This is the cone beam CT in a hybrid operating room, and this is the mobile CT unit, the images that it gives. It's quite comparable. You can see that you've reached a particular lesion with the tool that you've deployed. There's a little bit more snowflaking and some gray sort of discoloration, but essentially in most cases where the lesion can be seen, that's not pure ground glass change, it should be satisfactory. Of course, we then moved on to have some experience of using robotic bronchoscopy. We started doing it with very sort of early in our experience. We started in December last year. We've done just over 10 cases of using this new technology. And this is one of our first or second cases where we navigated to the right lower lobe, I think. And we used cone beam CT actually with the Orismonic system. And you can see on the cone beam CT in the hybrid operating room that we've definitely hit this lesion, which is about 1.52 cm in size, and got a diagnosis of adenocarcinoma. Of course, robotic bronchoscopy, we do hope that we are able to stretch it to use it for dye marking, which is already being used in US in a lot of cases, and also for placement of fiduciary markers for radiotherapy, and eventually to do ablation in the same way that we've been using navigational bronchoscopy to do ablation, but using robotic platform. Alternate energy ablations, we heard that from Joe and also from Jessica. Essentially, others to consider in the future, including steam vapor type ablation, as well as pulse electric field ablation for certain tumors that may be close to critical structures, as that doesn't really create much heat in the process. We did see one of the previous speakers mentioning potential for drug delivery into the tumor and having a carrier that will spread that particular drug or even genetic material that will alter how the cancer behaves in the future. And that's really exciting. And all of these, of course, you need a very accurate navigational platform, be it robotic bronchoscopy or EM platform, to get you to that particular lesion. So I just flew through ablation for you, and I think in a summary is that basically in very highly selected patients at the moment who are surgically contraindicated, gone through the MDT, and they are not candidates for other types of therapy or declined other types of therapy, this type of transbronchial microablation is feasible and is a safe technique for treating early lung cancers and potentially lung metastases. I think it really does have fewer poor complications when compared to percutaneous ablation approaches in literature, and has at the moment in our hands comparable early term local control rates. The midterm and the long term results are of course still pending and will be very interesting to see and analyze. So I think everybody can keep calm, and I think ablation is really here to stay, at least for now. And thank you all very much for the opportunity.
Yeah, thank you. Thank you, Calvin. I appreciate the concise talk and really pioneering work that you're doing. There are questions that were submitted by participants, again, during the registration process. And if there are more questions now, please use the chat room. But I have two questions for you. One is, what's the percentage, in your opinion, the percentage of lesions that actually need ablation for curative intent? I'm talking lung cancer, primary lung cancer, early stage, not oligometastatic disease, but stage 1A lung cancer that will require ablation. In other words, what's the percentage of non-surgical candidates and not SBRT candidates? Just to give us a perspective on like how often will this procedure be performed?
No, sure. That's a great question. I think it depends, of course, on your institution of how aggressive surgery is, and also how aggressive your radiation oncologist is in radiating the near field and so on. So we perform this ablation probably 4 or 5 times a month in our institution, and we are kind of we're getting referred more of these cases for consideration because there's availability of this technology. And I think also the radiation oncologists realize that for some cases it's better to have a local heat ablation than having blast from outside that can cause complications with regards to pneumonitis and also respiratory compromise. Sometimes a month or 2 after the radiation has been given, and of course there are areas where that the patients already had radiation and cannot have radiation again. And interestingly enough, we can actually ablate those. We can ablate the same areas many times as we want. And after the ablation, even if it comes back and we cannot ablate, we can send the patient to the radiation oncologist if the patient has not had radiation before. So we can be like the first line of local therapy in some ways, and radiotherapy can be the second line, if you like, in some aspects.
In those lines, we talk about thermal ablation a lot, and as you probably know, in the United States there were some concerns about hemoptysis, and I believe even in your case series you described that as well. And a lot may have to do with dosimetry, like how much energy should be applied, which I don't think we know for a fact. what the right dosimetry should be. So what about non-thermal ablation, like photodynamic therapy or intratumoral injection of drugs or nanoparticles? What's your take on that? And can you share your thoughts with us?
Oh yeah, absolutely. I think injection of drugs, as many of you are probably involved in early studies with a lot of companies now and looking into that kind of therapy of particles or viruses or lipid particles that can carry drugs, chemotherapy agents into that get be taken up into the tumor and can transfect the whole tumor, so you don't need to inject every single part of the tumor. There are, of course, also in development, that carriers of nucleic acid material that can be incorporated into the cancer and taken up and expressed by the cancer, very much like the vaccines that we have these days. And that can actually itself change the molecular behavior of the cancer to make it, much less aggressive and perhaps more amenable for therapy. So I think that's all in the pipeline in the next 5 to 10 years. So we really need to have a good ability to use bronchoscope to get to the lesion and maybe to different parts of the lesion to deposit these interesting drugs. In terms of photodynamic therapy, we haven't had any experience. We really try to get our hands on it, but in Hong Kong, it's there's only one photosensitizing agent that's available for kind of eye treatment. We don't actually have in our ability to get that material, chemical. I think it hasn't been very popular in Hong Kong because you do need to stay sort of out of the sun for a number of days afterwards. That's my understanding, and it's a little bit difficult in terms of patient preference or acceptance for that. But I see very good results in a lot of the studies that are pushing the boundaries in that area with peripheral lesions to doing PDT. I haven't really had experience with cryo either, although we've got cryobiopsy, but we're not ablation.
Yeah, there are some reports using electromagnetic navigation with PDT for non-surgical candidates, and I mean small case series, and definitely no hemoptysis. But I do think we need to learn more about the ablation zone. There are many other questions that I trust there will be some way of answering to the participants outside of this webinar, maybe contacting them directly using the CHEST platform, because we are indeed 20 minutes over time here. So if there are no other questions from the participants or the panelists, I do want to take this opportunity to thank the faculty for joining today and sharing their expertise and the review of the literature. I also want to thank Johnson & Johnson and CHEST for offering us this venue to share our experiences. So I hope you all stay well, but before we leave, I want to take each of you one at a time, and if you have to summarize your talk in one take-home message for the audience, what would that be? So Dr. Wang Mengli, we'll start with you.
Oh, you put me on the spot.
We'll go chronologically here.
I think, the technology that's coming out, this robotic technology, is really exciting. And so I think we have to see where it ends up and how it goes and what it really allows us to do. It's really exciting technology. I've really enjoyed having it and learning how to use it and then seeing what it can do. It's been pretty amazing.
Joe?
I can't believe you did this to me, Tim. The on the spot. Jessica let you off. Easily.
It's a desirable discomfort. Yeah. A desirable discomfort.
Desirable discomfort. Okay. I think I would say that we have some data right now that are promising. Nothing really differentiates either one now, robot. And however, I think that the tip integrity, the structural tip integrity that we have, and is applicable, especially with how Calvin talked about ablation and your questions on intratumoral therapy. We never would have been able to do that with a plastic catheter-based technology. So there you go.
And Calvin?
Yeah, so for Bronchoscopic ablation, I think, you know, I'm not necessarily recommending it as a therapy. I don't think it's really, you know, ready to so-called go into guidelines and prime time per se. We're still going through our series to look at midterm and long-term results as we reach our 3 years, mark with from our first case. But I think it is safe when it's done in select cases, I think. And, you know, we should not brush ablation aside and dismiss it. And it should be potentially discussed as a, form of treatment in our MDT. And because we have done a bit more bronchoscopic ablation, actually the discussion about percutaneous ablation in our MDT has also come up as a potential option, which was really just brushed aside very, previously. So, this is the place to watch in the coming few years, I think, as navigational technology, imaging technology, and ablation technology come together and become available more globally.
Thank you, Calvin. As for me, I would just tell the participants who had questions about the different systems and which one is better. There were questions about how do they compare and how do they compare with the traditional navigation technologies. I would say critical look at the literature. Please take a look at the methodology based on the issues discussed today, and then ultimately get your hands-on experience at training programs or at the corporate office, and decide on your own, what fits your practice. It ultimately may come down to philosophical approaches in believing in stability, in vision, etc. As more data and randomized studies are coming out. So until next time we see each other virtually or in person, please stay well, and hopefully you and your families will do well till the end of this pandemic. Goodbye, everybody, and thank you for joining our CHEST webinar series. Bye-bye.